Dr. George Chrysant. We talk about a very important and yet very challenging topic in cardiovascular disease. George, thanks for being with us.
Yeah, it's great to be here. I can't believe it's been 25 years that the meeting's been going on. I guess we're not getting any younger. So, but no, we had a good iliac session with some good live cases that illustrate the complexity of that area. And I always think it's important to go through not only newer technologies, but also remind everyone what's actually recommended in the guidelines so that you give some guardrails, if you will. But it's definitely an area that's exciting, and it's an area where the technology is outpacing the guidelines, which is the usual thing in cardiovascular medicine. But it's always good to level set the audience and just make sure everyone's on point in terms of what the current recommendations are.
If we summarize that session in bullet points, what is the top 3 or 5 points to take away when you are doing iliac intervention?
Well, so number one is to focus on safety. So we talked a lot about alternative access, different ways of crossing difficult lesions, but I think when you're talking about the iliac space, you always have to be very cognizant of safety issues. So you need to be prepared to handle dissections, perforations, ruptures. So you need to have equipment available that you can bail yourself out of trouble with. And then I think when and a lot of talk was on planning, so I think you have to think about how you're doing your procedure ahead of time and really think it through in terms of, is this a good case for radial access? Is it a good case for bilateral femoral access? And really think through not only your path to success, but think about potential complications and how you would deal with those, because it's a very unforgiving area.
So one last point about the role of imaging for planning a procedure. It should be a routine thing for planning for iliac intervention or just ad hoc?
Yeah, so I think in the iliac space, I would say it's very similar to how I approach left main coronary disease. Mandatory imaging, because I think that you have to know the size of the vessel and you have to know the lesion morphology. And if you know those things, then you will perform a safe procedure because you know exactly what you need to do and how to do it and what equipment, and it really can be a life-saving situation.
In terms of severely calcified iliac, is it a certain technique, rotational, orbital, or shockwave is preferred?
So I'm glad you asked. So atherectomy is class 3 in the iliac, so you don't use atherectomy. It's also a large caliber vessel, so IVL is becoming a very prominent tool, and rightfully so, because we don't have many other ways of dealing with the calcium in the iliac. So I think that's great. And then I think, judicious use of covered stents versus non-covered stents, because there's an economic side to things too. I mean, you can't just, or in most places, you can't just use covered stents 100% of the time because of the economics. But you certainly need to in some instances, and the data supports that. But in terms of calcium management, imaging, and then disrupting the calcium with IVL is probably the way to go these days.
Well, again, these sessions are all recorded, so for the iliac session, for people interested to know more, please tune in to that session on the NCVH website. Again, Dr. Chrysant, thanks for being with us.
Yeah, thank you.
A great insight on iliac intervention. Watch these videos and others on the YouTube channel. This is Chadi Alraies from NCVH 2024 in New Orleans. Thank you, George.
Yeah.